Welcome to this lesson about the role of imaging in acute coronary syndromes. My name is Patrick Sigrist. I work at the University Hospital of Zurich in the Department of Cardiology as an invasive cardiologist. Imaging modalities can be grouped into two different groups. First, the invasive imaging modalities and then the non-invasive imaging modalities. Let's have a look at all these imaging modalities in relation to the time course of death from cardiovascular disease, which has seen a decrease during the last 40 years. First, angiography has been developed in the 60s. It was then joined by echocardiography during the 70s, and then came nuclear cardiology during the 80s. In the 90s, around the 90s, cardiac MRI was developed, followed by cardiac CT, and then finally hybrid imaging, which combines the functional imaging of nuclear cardiology and the anatomical imaging of cardiac CT. First, let's discuss coronary angiography, which images directly the heart vessel by dye injection and X-ray. The dye is injected into coronary arteries by a catheter, which enters the body either at the groin into the femoral arteries or at the arm side into the radial artery. It then follows the artery just until the heart, where it finds the origin of the coronary artery just above the aortic valve. Coronary angiography can not only show the coronary arteries itself, but also other structures of the heart, such as, for example, the left ventricular, and show its motion. It can invasively measure pressures and gradients over valve, and it offers the possibility to treat a blocked artery directly. On the downside of angiography is that it is an invasive method and therefore carries the risk of complications. Also, it needs contrast media, which can cause allergic reactions, or it can be harmful for patients with impaired kidney function. It also needs radiation. The second imaging modality I want to show is echocardiography. Echocardiography is based on the concept of ultrasound, which is reflected in the body by tissues of different densities, and therefore an image can be generated. It shows the moving heart, however it does not show directly the coronary arteries itself. However, it is real-time, doesn't need any radiation, and is relatively cheap. It shows wall motion abnormalities, which can be caused by blocked coronary arteries. Therefore, it is helpful in patients with non-diagnostic ECG changes and ongoing chest pain. On the downside is a relatively short time frame in such chest pain patients to show those wall motion abnormalities. Sometimes also the acoustic window is poor, the imaging quality is bad, sometimes in obese patients. Also, it needs a lot of operator experience to analyze these images. Over the recent years, cardiac CT has been developed and offers also a very nice method to assess the coronary arteries, even look inside and show plaques itself. It also can assess the myocardium, the wall motion of the myocardium, and other structures of the heart, such as heart valves. It can also show pathological contents of the heart, such as, for example, tumors in the heart chambers or thrombi. Not only the heart can be imaged, also adjacent structures such as the aorta or the pulmonary artery. This gives the opportunity to CT to exclude other causes, other major causes of acute chest pain. Acute chest pain can not only be an acute coronary syndrome, but also a pulmonary embolism or an aortic dissection. This has led to the term of triple rule out, but actually CT can show more than only these three things. It can, for example, also show a pneumothorax, a Takotsubo cardiomyopathy, or any malignancy occurring in the thorax. So on the plus side of cardiac CT is a very high negative predictive value, approaching almost 100%. It is widely available and can be performed rapidly. Also, it can demonstrate alternative causes of chest pain. On the downside is again radiation and the use of contrast media. Last but not least, I would like to mention cardiovascular MRI for imaging in acute coronary syndromes. It actually offers a better way to detect acute coronary syndromes better than ECG and serum markers such as conventional troponin. It can assess regional wall motion abnormalities, can assess the left ventricular functions and volumes, and show the myocardial perfusion itself. It offers a high spatial resolution and doesn't need any radiation. On the downside, we find lengthy examination times, and therefore it is not widely available in emergency departments. So finally, let me summarize all these imaging modalities with their advantages and disadvantages. Angiography can directly visualize the coronary arteries and offers the possibility to treat them. The disadvantage is that it is an invasive method and carries the risk of complication. Therefore, it is only offered to patients with a high probability of having a blockage in the coronary arteries. Echocardiography is fast, cheap, and widely available. However, it offers variable imaging quality and needs operator experience to analyze those images. CT is also a very nice imaging modality, is widely available in emergency departments and offers a quick, accurate answer and a high negative predictive value. Also, it can assess other major causes of chest pain in the so-called triple rule-out. Cardiac MRI offers the best tissue characterization, can show wall motion abnormalities and the perfusion of the heart muscle itself. However, it needs a lengthy examination time and is therefore not widely available in emergency departments. Thank you very much for your attention.